All right, let's dive right into a really important and pretty complex topic, rectal carcinoma. Now, to really get what makes this particular cancer so unique, we've got to start with one big question.
So here it is, the question that really frames this whole explainer. Why is cancer in this very specific spot? We're talking the last 15 centimeters of the large bowels, so incredibly tough to manage. Well, the answer, really, it all comes down to one thing: location.
And that's our first section. You might think rectal cancer and colon cancer are pretty similar, and in some ways they are. But when it comes to treatment, oh, they are worlds apart. And it is all because of where the rectum sits in the body. I want you to think of it like an anatomical real estate problem. The rectum is just packed into this tight, bony space called the pelvis. It's literally rubbing shoulders with the bladder, with reproductive organs, and with all these critical nerves. So what does that mean? It means any surgery in there requires just insane precision to get the cancer out without causing some really serious life-altering damage to everything around it. Okay, so how does this thing even show up? From a patient's point of view, what are the red flags? Well, there are several key warning signs that usually kick off the whole diagnostic journey. The first sign, and the most common one by far, is bleeding. After that, people often notice a change in their bowel habits. And this can include a really specific kind of urgency, sometimes called spurious diarrhea. It's this desperate feeling like you have to go right now, but then only mucus or blood comes out. And one thing that's really important to get is that pain and weight loss, those are usually late symptoms, meaning the disease is already pretty advanced. And then there's this one really specific and honestly very distressing symptom called tenesmus. It's that awful feeling of needing to go, so you strain and strain, but absolutely nothing happens. If a tumor is in the lower half of the rectum, this symptom is almost always there, and it's a huge clue for doctors. So once a patient shows up with these symptoms, the next step is a deep dive, a full-on investigation. This is where doctors use some pretty advanced tools, not just to say, yes, it's cancer, but to figure out exactly how far it's spread. We call that process staging. And when you look at this, you can see right away why MRI has become the absolute gold standard for staging. An ultrasound, or TRUS, is actually great for measuring how deep the tumor is, but it can't see the lymph nodes. A CT scan kind of has the same blind spot. But an MRI gives doctors a super clear picture of both the tumor's depth and whether it's in the lymph nodes. That level of detail is absolutely essential for planning the right treatment. So all that amazing data from the MRI gets plugged into what is basically the GPS for cancer treatment, the TNM staging system. This thing provides the incredibly detailed roadmap that guides literally every decision that comes next. Now, there were older systems, like Duke's classification, but TNM is the universal standard now because it's just so much more precise. It creates this common language for doctors everywhere to map out the cancer and figure out the best attack plan. It's not just about putting a label on it, it's about predicting how the cancer will behave and tailoring the treatment, which means a huge difference in patient outcomes. So let's break it down. First, the T stands for tumor depth, and this is so important. It's not about the size of the tumor on the surface, it's all about how deeply it is burrowed through the layers of the rectal wall. Each layer it gets through means it's a more advanced local stage. Next up, N is for node involvement. This answers the really critical question: has the cancer started to travel? Has it broken out of the original tumor and made its way into the nearby lymph nodes? This is a massive factor for figuring out the risk of it spreading even further. And finally, we have M for metastasis. This is the stage where the cancer has gone long distance, spreading to other parts of the body. For rectal cancer, the number one spot it unfortunately tends to go to is the liver. So once the cancer is precisely staged with that TNM map, the clinical team can plan their attack. And when it comes to rectal cancer, the absolute mainstay of treatment has always been surgery. For cancers that are still just in the rectum and the nearby lymph nodes, so we're talking stages I, II, and III, radical surgery to get the tumor out is the heart of the treatment, the best shot at a cure. Now, for the more advanced stages, 2 and 3, treatment often kicks off with chemotherapy and radiation before the operation. The idea is to shrink the tumor down to make it easier for the surgeon to remove it completely. But radical surgery isn't a one-size-fits-all deal. The path the surgeon takes really depends on one single thing: how close the tumor is to the anal opening. If the tumor is high enough up, surgeons can do what's called a low anterior resection, or LAR. They take out the cancerous part and reconnect the bowel, saving the sphincter. But for very low tumors, they have to do an abdominal perineal resection, or APR, and this means removing the whole rectum and anus. The sphincter can't be saved, which means the patient will have a permanent colostomy. It's a truly life-changing outcome, and it's all decided by just a few centimeters. And that brings us to a